But the biggest problem I had back then was that the veterinarians had such an amounts of drugs that they prescribe within the veterinary office itself. Am I right on that?
So the medications, as long as they're being administered there, really don't fall under this.
No, well, I think the biggest worry we had back then was that if somebody breaks in and they can get all those drugs and they're powerful drugs, so I don't know.
And that would be a separate issue, right? With our Office of Controlled Substances Administration. So if there is theft or loss of a controlled substance, it would go to that. That would be a different issue. This is just the dispensing of medications.
So if I take my dog or cat in there, they can give the medicine to me?
Yes.
Okay, to take home with me.
Yes.
Okay, so that's considered dispensing.
Correct.
Right now, but if they also could write out a prescription and I could get it filled at the local drugstore.
Correct.
Okay. And is there any data that provides us with any information about veterinarians?
Sure. Actually, Anna, if you could talk about some of the studies that we talked about.
Does it happen a lot? I don't know.
I can't speak to exactly what may happen in terms of diversion, but I can tell you that several. So for example, there is the Technical Assistance Center under the BJA, Bureau of Justice Assistance, along with NASCA, who they have made it a best practice to report, because there may be potential for diversion, and also just to monitor. It's a gap that is currently open, that we don't know how many prescriptions are being prescribed, what the prescriptions are, and the quantity. So it would just close that reporting gap.
So that's what this bill is all about, to close.
Yeah, and it would be in alignment with current statute that is in place right now, that the PDMP is required to monitor all controlled substances that are dispensed in the state of Maryland.
Okay, thank you. Thank you very much.
Senator Hayes.
Thank you, Madam Chair. To the panel, I'm not sure if you all have had an opportunity to read the Maryland Farm Bureau's testimony, but part of their testimony explains that their reporting systems are not consistent or integrated with the prescription drug monitoring program. Does the department propose or anticipate any assistance in that integration, or what is the plan to address that barrier as far as them complying?
So I'll start and then I'll turn it over to Anna. So there is a separate reporting platform that for systems that are not integrated, there's a separate reporting platform. And we've actually walked through a few of the folks from the Maryland Veterinary Association to show them how this works. And it's a fairly easy process. But your question is more about integrating that system, right? And so I'm going to turn it over to Anna about, what that might look like.
So in terms of integrating the system, we have a platform, it's called RxGov, which the provider can sign on to and upload either an Excel spreadsheet or actually manually put in all of the medications. So within the past year, the PDMP as a program, we have tried to make that interface as seamless as possible. So in terms of, for example, if you're going to do a zero report, which is if you're not dispensing any medications, that can be done in less than 30 seconds. So, and we have demonstrated that as well. In terms of uploading information, controlled substance medications, that can be done within 2 to 3 minutes. In terms of integration within their programs, like their office programs, that would depend on the program that they're using. And I know that there are some, I believe Cornerstone is one of the places that is making it possible to integrate and report as part of the process when they have it in their, when their records are being updated.
Understood.
Does that answer your question, sir?
50%.
Okay.
The other part of it is the technical assistance, right? All things, as you articulated, aren't equal. Are there any opportunities for technical assistance for those who may be struggling to, figure out this new system or adept?
Actually, within the past year, we've been working on communication campaigns to inform prescribers how they can upload dispenses and getting all of the information into the PDMP, the importance of using the PDMP. And that is something that we had planned on doing from the beginning. When we researched with other states, one of the biggest lessons that we learned was that a lot of these statutes were put into place or requirements were put into place, but then they didn't have the teaching portion of it. And that is something that the PDMP is prepared to do. And we've actually been doing that with all providers. But we would be able to take the time and work with veterinarians to make sure that they are knowledgeable about how to upload. And we would work with them, yes. We have a customer service aspect to the PDMP.
Thank you, Senator. I think your panel's complete. We don't have any other questions, so thank you. I'm going to call two people that
Thank
were
you.
for. Thank you. We're for favorable with amendments, Ashley Nichols and Dr. Matthew Weeman's going to come up virtually, but Ashley, if you'd like to go now, please.
Okay. So would you like me to go first or? Okay. Is there a timer?
As soon as you start speaking, 2-minute timer will come up.
Okay.
Thank you.
Perfect. Hi, I am Dr. Ashley Nichols. I am a small animal veterinarian practicing in the state of Maryland, but I'm also the president of the Maryland Veterinary Medical Association. I am speaking on our position of favorable with amendments on SB 235. We've provided written testimony, and there is a laundry list of things within that written testimony that I can't address today. They're all focusing on many reasons why we should oppose this bill, but we're not so different at the MDVMA from our Maryland Department of Health colleagues in that we have the same goal of wanting to end opioid abuse and diversion. So we spent a lot of time over the last year trying to work on solutions to improve this bill. And while meeting their requirements, but also to lessen the burden on veterinarians. We had discussed and previously agreed to a permanent exemption for veterinarians to submit reports if they forego dispensing, and a 72-hour exemption for emergency dispensing. These are not without cause, and they are also, both of these are within guidelines for other states in the area that have PDMP. The main thing with the 72-hour dispensing is we want to be able to bridge gaps in care so that areas where there isn't a pharmacy available, we can prescribe medication so that patient can get a medication, and then the owner can go and pick it up when the pharmacy opens. There's lots of times, we all know, emergencies never happen 9 to 5. So with this being said, there's also a lot of flaws and things like that with the system itself still. And I know that was one of your guys' concerns.
Thank you very much, Dr. Nichols. And now we're going to hear from Dr. Weeman.
Hello, thank you. Yes, I'm Dr. Matt Weeman, a mixed animal veterinarian practicing in multiple counties around the state of Maryland, as well as the legislative committee chair representing the Maryland Veterinary Medical Association. And I also would like to refer the committee to our written testimony, which provides greater detail on our position of favorable with amendments for SB 235. For now, I just want to highlight that in spite of the tremendous controversy surrounding PDMP reporting for veterinarians, we did work hard to come to compromise with the Maryland Department of Health over the last year. Ultimately, while there were many reasons we disagree with MDH's proposal to include veterinarians in PDMP, we were at a point of accepting the bill when the Maryland Department of Health had agreed to our two key provisions: a permanent exemption of veterinarians to submit reports if they forego dispensing, and a 72-hour exemption for emergency dispensing. And after the Maryland Department of Health walked back those commitments they had previously made in the last session, we've been forced into a position of effective opposition to the bill. Our requests are well in line with our neighboring states. Virginia currently has a 7-day exemption for veterinarians. Pennsylvania has joined the majority of 35 states who have entirely exempted veterinarians from PDMP altogether. Delaware allows for a 3-day suspension of controlled substances and also exempts veterinarians from the PDMP. And in regards to integration, specifically Cornerstone, which is the software I use in small animal practice, I've talked with the manufacturers of Cornerstone, and they've assured me they will not integrate. I do appreciate the MDH creating a separate platform to make it as easy as possible, but at the end of the day, given the nature of the request, we recognize this bill is likely to pass, and we're at least trying to make sure that veterinarians of our state aren't being forced to spend an excessive amount of time reporting on something that none of the data available seems to support has any merit to the protection of public health or the mitigation of the opioid epidemic.
Thank you, Doctor. That ends the testimony for favorable with amendments, and I have one more person to testify. Oh, I'm sorry. Senator Gao.
Thank you, Madam Chair. I just have one question for the panel. Other than the obvious as to who or what is the intended recipient, I was just wondering if the panel could speak a little bit about how the drugs that they dispense are different from the drugs that a physician dispenses.
Yeah, so if I can start with that, it's hard. I'm sorry, I can't see what Ashley's doing, so I don't mean to be stepping over. Ultimately, one of the key differences, particularly in a medication that's an opioid like tramadol, which we may prescribe in small animals, the doses tend to be slightly higher than that would be typically dispensed in, for instance, a human. But at the same time, if we limit a 3-day dispension, it's still a fairly, in our opinion, and from the 2019 study that looks at this, a de minimis amount of tramadol going out the door. Another medication that we commonly use would be hydrocodone. Fortunately for the human side, hydrocodone is almost always combined with hematropine bromide, which is an additive agent that basically makes the patient sleepy. So essentially it's like cough syrup. And when you hear hydrocodone, you think, oh, that's a nasty opioid. And it is commonly used in veterinary medicine to help dogs with coughing problems, particularly small dogs. So we tend to use small amounts of it, but we use it in combinations that specifically address concerns regarding diversion and abuse. And so many of the medications might be prescribed in different quantities, but you know, the medications that we typically use, and we have more survey data that will be available to the committee as we compile it, shows that of the harshest, highest abuse potential drugs, veterinarians in the state are not using them. And if they are using them, they're prescribing them, they're not dispensing them. So they would already be subjected to PDMP oversight. I want to make one other point about drugs for veterinarians specifically. The distributors of these medications are already providing oversight statewide for veterinary practitioners who are using them. So if I order a drug in my hospital, the pharmacy will compare my use. Anything that's unusual about it, they're required to report. Additionally, they're required to report it if my use, say in a 1-doctor hospital, is significantly different than Dr. Nichols' use in her 1-doctor hospital. So we already have a mandatory reporting structure in addition to the DEA regulating our use of these medications.
And then I just wanted to add, somebody had mentioned earlier about us dispensing morphine. Morphine is an injectable. You can't dispense that. So I don't know of any situation where that would be dispensed. Morphine is used, but it's administered in the hospital. It's a hardcore opioid medication. But if we're doing something like a limb amputation, I think you would want your pet to have that medication. But we're not going to give you, for the same reasons that we're not going to give you fentanyl for pain management to take home with Fido. We're not going to dispense, morphine home. We're going to keep the animal hospitalized until they can be sent home. And that's the other thing is a lot of stuff. I don't know if anyone has ever tried to give their animal medications and watch the Simpsons episode where they've tried to get stuff in the dog's mouth, out of the dog's mouth. That happens on a regular basis. So we as veterinarians understand. And when we're dispensing things, we try to make it so that it does us no good to send the meds home if it's not getting into the pet. So we're going to be doing things that are liquid, but there have things like the hydrocodone HBr that makes it so that essentially your dog is not coughing because they're sleeping, and it calms things down. But also we're going to do it in formats that are easier for you. So tramadol tablets and things like that, just because that's our goal, is for the pet to get better.
Okay, thank you. Thank you, Madam Chair.
Thank you both very much. Thank you, Secretary, Senator. Dr. James Plora. See. Wait a minute. Oh, I'm sorry.
Oh, yeah.
Sorry, Madam Chair, I gotta be quicker with my button. I waited and that's my fault. I apologize. This was new to me and I'm interested in, so how, what are the, is there information on how veterinarians are prescribing opioids? I mean, out of all the medicines that are being prescribed, because I wasn't really aware. I mean, I knew of certain things. We had a procedure. My mother has a standard poodle. And he's a pretty high strung wild thing and runs all over the house. And I came home one day and he was like just laying there, and he had been to the doctor's office and they had given him some medicine, and it was like the most peaceful time. And then he woke up and all heck broke loose again.
So there is, you know, we've done a survey. Unfortunately, we just got the results in from the survey of veterinarians in the state. Literally like 48 hours ago. So we're still complying or, you know, complying the data, but based off of our data, the majority of opioids and controlled substances are utilized either through prescription, and it's for things like seizure pets, you know, your pet getting phenobarbital because it's seizing. So that's a long-term chronic use that's going to be, you know, monitored through the pharmacy. And then the other main way that we're doing it is through administration. So that's for surgeries and things in the hospital, or in the case that, you know, we need your dog to calm down a little bit because they maybe torn toenail or something like that. So we physically are giving them medication in the hospital. No lay person is coming in contact with that medication. And so most practitioners are doing due diligence to ensure that those pets needing those medications are not going home until they can be off those medications.
And we sent out a survey to about, I think it was 2,500 licensed veterinarians in Maryland. We've received, I think it was about 600 or 1,500 veterinarians, 600 responses. Forgive me if those numbers aren't precise. We'll get them to you as we compile it. We waited to get that survey out because it is a time-intensive issue, and we really thought we were coming to points of agreement with MDH on this. But now we recognize we probably need to have more data for the committee to specifically review this. Certainly what we're seeing so far in Maryland, and again, we'll get you the rest of the information, is that our data is mirroring very closely the last nationwide study in 2019 that showed veterinary prescriptions are less than 0.3, veterinary prescriptions for opioids are less than 0.34% of those that are prescribed nationwide. And so while I recognize Anna's point that MDH doesn't have the ability to track dispensions, we're specifically getting that data for our state from our practitioners in a way to provide it. And it looks like the majority of our practitioners, again, we'll get you the numbers, are prescribing the most high risk categories of medications that would be diverted. They're only dispensing those, or they're only administering those in the hospital if they use them. The majority, it seems, aren't prescribing. I'm sorry, the majority aren't dispensing any of those medications at all. So they wouldn't even dispense it for 3 days. They would prescribe it, which again is going to put it in the PDMP database as is. So we'll get more concrete details specifically on Maryland, but nationwide, there have been surveys, and that's why 11 states have now, after putting veterinarians in their PDMP systems, the majority of states don't include veterinarians in PDMP, and 11 states have now come back and said, we want veterinarians out of this system. This system is designed to track human drugs. It's not designed to track animals. Veterinarians don't practice on humans.
Thank you very much.
Thank you, Senator. And you'll get some more information to us on the survey.
We will, yeah, and we're compiling that and we'll get that to you in due diligence.
Thank you very much. Thank you both. If there are no other questions, no other lights. Dr. James Pelor, are you here? Oh, I'm sorry.
Bear with me. And I'm not taking opioids. Good afternoon. My name is James Pelor III. Is this on? Okay. I'm a private practitioner, veterinary practitioner in Davidsville, Maryland. I hold a master's degree in animal nutrition and a doctorate of veterinary medicine from Purdue University. The comments below represent my opinion, and I am not speaking on behalf of the Maryland Veterinary Medical Association. I am here today in total opposition to Senate Bill 235 for the following reasons. I assume that this bill is an attempt to combat the opioid crisis in our state and our country. In reality, according to several recent studies, the impact of opioid drugs coming from veterinary practices is less than 1%. And I have a report from the Journal of Rural Health recently. The most frequently reported veterinary medications misused in humans were analgesics, anti-inflammatories, anti-arthritis medicine, and systemic antibiotics. Also, veterinarians are already strongly regulated by the Maryland Board of Veterinary Medical Examiners, the DEA, and by the companies that supply these controlled drugs to us. Recently, there was a veterinarian sentenced to 15 years in jail for selling equine anabolic steroids. The DEA was alerted to this by the company that were selling her all these drugs. They alerted the DEA and said, this practitioner is too small to be using this many drugs. So due to the confusing and time-consuming nature of the PDMP, many small veterinary practices would have to hire additional staff, which would impact the practice's bottom line. The increased costs of the practice would ultimately be passed on to the animal owning public, thus increasing the cost of their veterinary care. I have two more sentences. The PDMP is very complicated, and I can provide a video to any one of you showing how this works. My final comment is this. As I see it, this is a thinly veiled attempt by the Maryland General Assembly to confuse our citizens into thinking that our government is serious about fighting the opioid crisis. Thank you.
Thank you very much. Any questions for Dr. Pelor? Thank you very much.
You're welcome. Thank you.
And that ends the hearing on Senate Bill 235. Our next bill is Senate Bill 230, and it's the Maryland Insurance Administration. And Jamie, you want to come to the table? Thank you.
Thank you very much, Chair Bidle, Vice Chair Klossmeyer, and members of the committee. My name is Jamie Sexton. I'm here on behalf of the Maryland Insurance Administration, where I serve as the Director of Legislative and Regulatory Policy. I'm here to share MIA's support of Senate Bill 230, which is a departmental bill. This is likely one of the simpler pieces of legislation you're going to hear today, pretty straightforward. The bill proposes an amendment to the insurance article to permit small businesses, which are those with 50 employees or less, to designate an employee to represent them in administrative proceedings before the MIA or hearings at the Office of Administrative Hearings on behalf of the MIA. The language used in this departmental is very similar to language used in enacted legislation that allows representatives of small businesses to appear without counsel to represent the business in Maryland's small claims court. This places Maryland small businesses on equal footing with insurers, which are not required to be represented by attorneys in evidentiary hearings before the MIA. For many small businesses, the cost of hiring counsel is often a significant economic barrier to exercising their right to pursue an evidentiary hearing. Rather than being represented by its owner or an officer of the company, small businesses are currently required to hire an attorney because representing a person, which includes a business entity, before a unit of state government is deemed to be practicing law, and an individual must be a member of the Maryland State Bar, except as otherwise permitted by statute. The inability of small businesses to incur the expense of counsel is a reason that the MIA has seen many small businesses abandon their hearing requests, and a reason for which either the MIA or the OAH have been forced to dismiss a case on motion of the insurer. As such, we view this measure to be an important level set for Maryland small businesses and urge a favorable committee report on Senate Bill 230. Thank you for the opportunity to share our support.
Thank you, Jamie. Do we have any questions? We have no opposition. We have no other witnesses. So this ends the hearing on Senate Bill 230. Thank you.
Wonderful. Thank you.
Next, we have Senate Bill 229 from the Maryland Insurance Administration, Joseph Smith.
Good afternoon. My name is Joseph Smith. I'm the Acting Associate Commissioner with the Maryland Insurance Administration's Fraud and Enforcement Division. The Maryland Insurance Administration appreciates the opportunity to share its support for Senate Bill 229, which is a departmental bill. Senate Bill 229 proposes to increase the maximum civil penalty that can be assessed against an insurance producer or public adjuster for violations of the insurance article. An unlicensed person engaging in the business of insurance in the state in violation of state licensing requirements. In both instances, the minimum penalty will remain the same. In the current statute, insurance producers or public adjusters who violate the obligations or standards imposed by the insurance article are subject to a minimum penalty of $100 and a maximum penalty of $500 per violation. Senate Bill 229 proposes to increase the maximum penalty, which has not been changed since 1963, from $500 to $5,000. This penalty is consistent with the maximum penalties for violations by licensees regionally adjacent to Maryland. With certain statutory exceptions, persons engaged in the business of insurance in the state are required to be licensed. A person who violates the licensing laws is subject to a penalty ranging from $1,000 to $50,000 per violation. Senate Bill 229 proposes to increase the maximum penalty, which has not been changed since 1987, from $50,000 to $125,000. The current cap is out of sync with the cap on the maximum penalty that can be imposed on those licensed by the MIA, which is $125,000. The current maximum penalty no longer serves as an adequate deterrent. There have been instances where the insurance commissioner was limited in the penalty to be imposed against an unauthorized insurer operating due to the current cap. To ensure adequate deterrence of unlicensed and fraudulent actors, the Maryland Insurance Administration proposes that the penalty cap be raised to $125,000. For these reasons, the MI urges a favorable report from committee on Senate Bill 229 and thanks the committee for the opportunity to share its support.
Thank you, Mr. Smith. I do have a question. How often do you find someone who's operating as an agent that's unlicensed?
I don't have the numbers on that, but we can get those numbers.
I actually experienced that with a colleague, and he was issuing insurance policies. You know, he had he was licensed, but he was issuing his own insurance policy and collecting the premium pocketing. And people get really hurt by that when then there's a claim and there's
Absolutely.
no coverage in effect. So
We have seen that.
I think it's a very serious violation. So do we have, Senator Motz, you have a question?
Thank you, Madam Chair. I was just trying to find follow you with the increases. I was reading the fiscal note at the same time. Can you just summarize what the proposed increases are? So it's for a public adjuster or an insurance producer. Currently, it's 100 minimum, 500 maximum. That was last codified in 1963. We're proposing to increase it from 500 to 5,000. And for unlicensed insurance business, it's currently 1,000 and 50,000. And that was last codified in 1987. And we're looking to increase it to 125,000. When you say looking to increase it, is that the minimum?
The
or
maximum, the minimum does not change in any of these. The
I
maximum
got you.
changes.
So it's going, you're moving 500 to 5,000 and 50 to 125.
Yes, sir.
Thanks.
Senator Hershey?
Thank you, Madam Chair. I'm not sure if I'm saying exactly what you said or not, but how many penalties have been levied over the last number of years?
So we would have penalties for public adjusters or
Right, and just
or producers.
for each of them that we're looking to increase the penalties, well, I mean, if these penalties were in place for so long a time, are we seeing repetitive violations of these, or is it just, we're just increasing them because they haven't been increased?
It's not an adequate deterrent. I don't have the numbers. I can certainly get those for you, but $500 when they are managing as the situation that the chair introduced, they're making a lot more money by committing these fraudulent acts, and the penalty is so low, it's not a deterrent.
Right, I understand might not be, the penalty might not be a deterrent, but are we seeing those bad practices taking place?
We are.
And you are levying penalties?
Yes, sir, we are.
And you can give us some data on that?
We can give you some data on that.
Okay.
Yes, sir.
Thank you very much. Thank you, Madam Chair.
Any other questions on Bill 229? Thank you very much. Mr. Smith, if you'll stay at the table, you're now going to do Senate Bill 231.
The Maryland Insurance Administration appreciates the opportunity to share its support for Senate Bill 231, a departmental bill, which seeks to protect Maryland consumers from predatory business practices that often occur after severe weather or other catastrophic events that give rise to an insurance claim. During and in the immediate aftermath of a disaster, consumers are vulnerable and not in a position to fully assess their need to pay third party to assist with the claim. The bill, with amendments, places limitations on solicitations by public adjusters, including a prohibition from soliciting during a loss, no solicitation between 8 p.m. and 8 a.m., allows for additional time to cancel a public adjuster's contract for consumers 65 years of old or older. The amendment addresses and replaces a proposed ban on solicitation during 24 hours following a loss, which was challenged as unconstitutional. While the MIA does not concede to the merits of the position, we have an interest in advancing this important consumer protection. It is not unusual for a public adjuster to arrive and solicit business from homeowners during a loss, such as a fire. Last year, during a fire, consumers reported that while the fire department was still extinguishing the fire, a public adjuster was on scene soliciting business. The consumers believed that it was an adjuster from their very own insurance company. That's just one example of complaints that we receive from consumers, fire departments, local governments, and legislators. It demonstrates a need for additional protection. The bill will afford immunity from lawsuit to persons who report violations committed by public adjusters and those acting as public adjusters without a license. The bill broadens an existing protection against insurance fraud. Maryland has long prohibited contractors from inflating the cost of storm-related repairs to cover an insurance deductible. Expanding the prohibition to include home repairs covered by insurance, Maryland market is better protected. Inflating repair costs results in higher insurance premiums for everyone. The MIA is confident that Maryland consumers are best served by this protection included in this bill. For these reasons, the MIA urges favorable committee report on Senate Bill 231 and thanks to committee for an opportunity to share its support.
Mr. Smith, I have a question. Exactly what is your amendment changing?
It's the 24-hour requirement that prohibited a public adjuster from soliciting business within 24 hours of the loss.
Okay. I certainly understand the concern. I mean, when I was an agent, I had shown up at fires and, major claims, and I can see where they would be confused whether it was the agent or the adjuster or the public adjuster. So, I appreciate that, but thank you. Do I have any other questions from anyone? Okay. Oh, I can't see it. Senator Kramer.
Thank you, Chair. Quick question. I see that you have the right of rescission, which is good. Is there any notification to the consumer that that they have this right of rescission? In other words, and I'm just glancing at it, but is there a requirement to provide somehow notification so that the
Yes, sir.
consumer is aware of this?
It would be in the public adjuster's contract. That it would be required to be included in the contract that the consumer signs about their
Okay.
right. Yes.
Providing them with knowledge of the
Yes, sir.
right to cancel. Great. Thank you.
Senator Reedy.
Thank you, Madam Chair. Can I just ask, and maybe I just don't understand the process very well, but why would we limit the hours of when someone could solicit business? I mean, I see we're 8 AM to 8 PM, and I would actually hope somebody wouldn't be dumb enough to call somebody at 6 in the morning to solicit business, but why do we need to put that in law?
The public adjusters are actually showing up contemporaneous with the loss. So imagine your house burning down, someone comes up with a warm car and a cup of coffee and says, sign this contract and I'll take care of your insurance claim. What we're hearing from consumers is they are of the opinion and belief at that moment when they're most vulnerable that this person is with their insurance company and they're signing the contract without fully reading the contract. And then they can't, and the public adjuster is taking a fee that is a percent of the claim, which reduces the amount it may need, the consumer may need to make the repairs to their home.
But if, I understand, and that's bad, and we don't want that, but with 24 hours, if we're already gonna say you can't solicit a client in 24 hours, why do we need the 8 to 8?
The amendment is taking the 24 hours out.
I see, okay, I
original
heard you say that,
proposal.
but I didn't make the connection, okay, thank you.
Senator Ellis, please.
Thank you, Madam Chair. Thank you, sir, for this consumer protection bill. I have a question. You mentioned solicitation during a loss. So I can understand, say, fire, it's burning, the fire department is there, okay. But how about like a flood or hurricane? A flood that might, high water might be for around a week, or hurricane with high winds, and how do you define that loss as, is it defined in the bill or not?
It's not defined in the bill. Maybe you can take this one.
So what we're doing as a part of the amendments is we're looking at determining what the occurrence would be and actually probably passing regulations that'll make it clear as to a fire. Oh, I'm sorry, Joy Hatchett, Associate Commissioner for Consumer Education and Advocacy on behalf of the Maryland Insurance Administration. I apologize. So basically taking each incident, a fire would have a certain amount of time, a flood, a different amount of time, a hurricane, all of them would be based on the occurrence because different occurrences have different scopes of time when people are approaching these consumers.
Yeah.
And also to go back to the question that was asked before yours, this morning, we had a consumer that complained specifically about the public adjuster after 8 o'clock at night, showing up with the contractor, basically leading the consumer to think that they were there on behalf of the insurance company. So this is a very, very real problem.
Yeah, thank you for clarification. So did I understand you correctly? You'll submit amendments to this bill, or you'll take care of the time periods for each particular scenario in the regulations that you'll pass after the bill is
Right, there will be amendments to the bill, but the timeframes will be a part of the regulations.
Okay, great. Thank you. Thank you, Madam Chair.
Thank you, Senator. So if there are no other questions for, what?
Could one of you just explain what a public adjuster is?
Yes, ma'am. A public adjuster is someone that a homeowner who experienced a loss, and it may be a catastrophic loss that requires some degree of expertise governing the policy and procedures of handling the claim. And maybe the homeowner needs assistance with addressing that claim that may be catastrophic, such as a fire. But that public adjuster does not work for the insurance company. That public adjuster is independent and works for the homeowner or the insured.
Okay, so if I have a fire at my house and one of these public adjusters come, and I think I would probably think they work for the insurance company. Is that what happens?
That's the information we're receiving. That's the thought process.
Yes.
They're
So
vulnerable at that point.
If anybody is watching this by streaming, they may have learned something about their insurance policy.
Yes,
So,
ma'am.
thank you.
Thank you very much. We have two additional witnesses, Matt Overturf and Nancy Egan.
Good afternoon, Madam Chair and distinguished members of the Senate Finance Committee, and my first time down in Annapolis, so it's good to see all the new faces. I represent the American Property Casualty Insurance Association, and our members write 61.8% of all the property casualty insurance in Maryland. We appreciate the MIA submitting this legislation, which prohibits a public adjuster from soliciting or attempting to solicit a client. But I understand that there's going to be some amendments to that time period, and we look forward to seeing them. This bill will align Maryland with the NAIC Public Adjuster Licensing Model Act, which Maryland did adopt, but we did not adopt the cooling off period, which had been in the initial draft. Insurers know all too well that experience a fire or storm or a large hurricane loss to one's home is highly stressful. And these events do not happen at any time. They can be at 2 a.m. in the morning, which we've already heard. So protecting the consumer from that stressful situation as someone being approached from a public adjuster to sign a contract is really a good effort on the MIA to protect the consumer. In addition, we appreciate the fact that a consumer 65 years and older has a 7-day time to cancel the contract with the public adjuster versus the 3 days. And with that, we support the bill, and I will take any questions. Thank you.
Ms. Egan, I do have a question. What was the original cooling off period? You said it was not incorporated in the prior legislation.
It did not have, they didn't adopt a cooling off period
But
when they
there was
originally
one-
adopted.
There was one recommended or wasn't?
I don't have that for you, but I can find out.
Thank you.
Thanks.
Chair Bidle, members of the committee, my name is Matt Overturf on behalf of the National Association of Mutual Insurance Companies. Thank you for the opportunity to speak in support of Senate Bill 231. NAMIC consists of more than 1,500 member companies, including 7 of the top 10 property casualty insurers in the United States. I want to begin by thanking Commissioner Brain and her team for bringing this important legislation forward. Over the past year, NAMIC has been very involved at the National Council of Insurance Legislators, or NCOIL, developing a national model law to provide important consumer protections with regard to public adjusters. Senate Bill 231 strengthens existing Maryland law and provides consumer protections by the various ways that have already been outlined this afternoon. And so for these reasons, NAMIC supports this important consumer protection legislation and recommends its favorable passage. Thank you.
Thank you. Any
Okay.
questions for this witness? Thank you very much.
Thanks.
Thank you.
Ends the hearing on Senate Bill 231. Next, we're going to hear Senate Bill 228, and we have David Cooney with Joanna Fabian Marks and Michael Patty.
Thank you, Madam Chair, members of the committee. I'm David Cooney, Associate Commissioner for Life and Health with the Maryland Insurance Administration, testifying in support of Senate Bill 228, which the MIA developed in collaboration with the Maryland Health Benefit Exchange. So this bill makes a very straightforward change, and it's intended to merely codify the status quo and maintain an important consumer protection. Specifically, the bill removes a provision in state law that currently permits health benefit plans sold on the exchange to exclude coverage of pediatric dental benefits. Pediatric dental is one of the 10 essential health benefits that must be included in all individual and small group plans under the Affordable Care Act. However, federal law allows qualified health plans to exclude coverage of pediatric dental as long as there are at least one standalone dental plan offering pediatric benefits that is available for purchase through the exchange. Because multiple standalone dental plans have been offered on the exchange every year in Maryland, health carriers are permitted to exclude the pediatric dental benefits. However, historically, carriers have elected to voluntarily include those pediatric dental benefits in the health benefit plans. We've had some new entrants enter the market in recent years, and there are concerns that if a new carrier would choose to exclude pediatric dental, the MIA would lack the authority to prohibit them from doing so. And the primary concern if this were to happen is consumer confusion. Since all plans currently include pediatric dental, consumers generally assume that these health benefit plans they purchase through the exchange are going to have those dental benefits included. In the off-exchange market, if a consumer applies for a health benefit plan that doesn't have dental embedded in the product, the consumer is required to attest on the application for coverage that they understand this and that they purchased a separate dental plan. This self-attestation does not apply on exchange, however, And additionally, due to the way the plans are displayed on the Maryland Health Connection website, there's really not an easy way to conspicuously differentiate between the plans that may have dental and the plans that don't have dental. Therefore, for these reasons, there are concerns that consumers may not be aware if they're purchasing a plan without pediatric dental. Since dental is such a critical benefit for children, ensuring that all health plans sold on the exchange continue to cover pediatric dental benefits is a very important consumer protection. There are some other states that have passed similar laws, and we can do this in Maryland with no disruption to the market since all health carriers are currently doing this anyway. For these reasons, we urge the committee to adopt a favorable report.
Thank you. Do I have any questions for Mr. Cooney from the MIA? No, thank you very much.
Sure. Hi. Thank you, Chair Beidel, Vice Chair Klausmeier, and members of the committee. I'll keep it brief. I'm Johanna Fabian Marks, Director of Policy and Plan Management at the Maryland Health Benefit Exchange. We support the bill for the reasons related to consumer confusion that David mentioned. I'll also mention that if a carrier were to come onto the exchange and want to exclude pediatric dental, we would have to go through a series of system changes, including changing the way that we calculate premium subsidies, and then we would also want to change the way that we present plans to flag which plans exclude pediatric dental. We haven't calculated a specific fiscal impact for that, but it would be IT work and there would be a cost impact to the exchange. So for these reasons, we urge a favorable report.
And Michael Patty here this afternoon on behalf of the Maryland Dental Action Coalition, an oral health advocacy organization who works to improve all oral health for all Marylanders, and the Maryland Community Health System, a network of federally qualified health centers across the state of Maryland, in support of Senate Bill 228. Anything that removes barriers to access and confusion when on the exchange trying to get a health plan is something that we can certainly support. And we just want to thank the exchange and the Insurance Administration for their work on the bill.
Thank you, Michael. Do I have any questions for this panel? Thank you very much. Mr. Cooney, if you'll stay with us, we'll hear your testimony first on Senate Bill 217.
Thank you, Madam Chair. Once again, for the record, David Cooney with the MIA, testifying in support with amendments for Senate Bill 217. Senate Bill 217 is intended to conform Maryland health insurance requirements to federal law. As many committee members are aware, the MIA has submitted a conformity bill nearly every year since the Affordable Care Act was enacted. The General Assembly has previously codified many federal health insurance requirements directly into state law. And as those federal laws and regulations change, we often have to update Maryland law to ensure that our laws continue to align. It's important to note that health insurance carriers are required to comply with these federal requirements, regardless of whether the provisions are codified into state law. However, assuring the state law aligns with federal law provides the MIA with clear statutory authority to directly enforce these requirements. It also provides greater clarity to the insurance industry when Maryland statutes conform to federal laws. And for this reason, the industry has historically been very supportive of our conformity bills. We haven't, as an agency, submitted a conformity bill in a few years, and there have been some recent changes to federal law that now require updates to Maryland law. I'd be happy to go into greater detail if there's any questions, but just to summarize this year's bill, we're proposing a handful of changes to address recent updates to federal regulations for the Affordable Care Act and the No Surprises Act. Most notably, there are revisions to the definitions of emergency services and emergency medical conditions to ensure that Maryland law is consistent with the corresponding definitions in the No Surprises Act. There are also several provisions where current state law directs the MIA to refer to federal requirements for the Affordable Care Act that were in effect in 2019 if the MIA determines it is necessary to adopt regulations to implement those requirements. Since the federal laws have been amended since 2019 to the benefit of Maryland consumers, we're now seeking to update that date from 2019 to 2023. The bill also implements recent Affordable Care Act regulations that made a minor revision to a special enrollment period for small employers and a technical revision to the open enrollment period in the individual market. Finally, we'd like to note that after we submitted the bill, we did become aware of one additional provision where that 2019 effective date that I mentioned previously needs to be updated to 2023. So we're currently working with the sponsor and the committee staff to draft an amendment to make that correction. So to ensure the MIA retains clear authority to enforce the federal requirements, we're urging the committee to adopt a favorable report.
Thank you. Do I have any questions at all for? Yep. Thank you, Senator.
Thank you, Madam Chair. Just a question. I'm trying to read through this bill a little bit. I know we get a lot of these conformity bills. I'm looking on page 3. Emergency services includes or means with respect to an emergency condition, a medical screening examination that is within capability of emergency department or freestanding medical city, including ancillary services routinely available to the emergency department. Is this two things? What would be an ancillary service, an example of an ancillary service?
Sure. I mean, it could be things like anesthesia services and things like that. There's a whole list in the federal regulations. I frankly have not looked at that list recently, but I could, if you like a more follow-up, I could give you the complete list.
If there is a list, I would love to see it, and I certainly understand you don't have it all memorized. The other question is that section here, is this about what's covered? Like what's required to be covered under the Affordable Care Act or what's, yeah.
So this is primarily, I mean, they are required to be covered, first of all, but this is more intended to address that they're required to be covered at the in-network rate with no balance billing or surprise billing to the consumer. So for example,
Right.
if it's an emergency, you just go to whatever provider is available. If that hospital emergency room happened to not be in your network, this definition is what is used to determine that it's considered an emergency service and you're protected from balance billing.
Was this something that was passed, that this particular, was it passed recently with, as it relates to, it was passed as it relates to the no surprise billing?
Yes, it was, we have definition of emergency services in Maryland statutes for a while that were very similar to the No Surprises Act definitions. But when that law was enacted, there were just little minor changes that were made where we needed to conform our language as well.
So if this ancillary service would refer to things that were covered by federal already, correct? So,
Yes.
all right, there's not anything new we're adding?
No, this is just completely conforming to federal law. And we already have a statute that gives the MIA broad authority to enforce the No Surprises Act. So this is more just a technical cleanup to make sure the actual language of our definition is completely consistent with the federal definition.
Okay, thank you. If you would send me that list,
Absolutely.
just because I'm trying to learn more about these things. Thank you.
Thank you. If there are no other questions, thank you very much,
you.
Associate. And Deborah Bricado, she's favorable with amendment.
Good afternoon, Senators. On behalf of our 200,000, Deborah Bricado with Maryland Right to Life, 200,000 followers across the state, we do respectfully object to this without amendments because the bill will use taxpayer funds to further subsidize the abortion industry unless an amendment is added that explicitly excludes abortion facilities from the application of this bill. While it's meant to conform with the federal No Surprises Act, it adds to it with the inclusion of these freestanding medical facilities. Abortion facilities are a type of freestanding medical facility, but are not emergency facilities. In addition, it expands the classification of an emergency medical condition outside of the actual diagnosis codes, and this is on page 7. And it doesn't give conditions upon reaching outside of those diagnosis codes. So pregnancy is not ordinarily an emergency. When pregnancy is an emergency, as in the case of ectopic pregnancies, miscarriages, or a type of high-risk pregnancy, the mother is treated at a hospital, not an abortion facility. Because there is no longer a physician requirement for abortion facilities because of the Abortion Care Access Act, an abortion facility does not substitute for an emergency care facility. And then there are other sections of the bill that are vulnerable for being used to pay for out-of-state abortion clients. Ancillary services, freestanding medical facilities staffed by behavioral health providers. So in Maryland, health of the mother includes mental health where abortion is considered a treatment for things like anxiety and depression. Although mental health can be an emergency, like in an acute crisis, the pregnancy itself is not the problem, and it wouldn't be an emergency, especially when in Maryland, there's not a limit. We have unrestricted abortion here in Maryland. So we are concerned that this would be used to pay for also out-of-state clients. Abortion in Maryland is unrestricted and fully funded by the taxpayers of Maryland, so we don't need additional funding to go for that cause. Okay. All right, thank you.
Our next bill is Senate Bill 227, again from the MIA. Mary Quay, if I said that right. Please correct me if I'm wrong. Thank you.
It's Mary Quay.
Quay, thank you. And Joanna, Fabian Marks, if you'd like to come up, you can also come up. Thank you.
Good afternoon, and my name is Mary Quay, and I am the Associate Commissioner for Market Regulation and Professional Licensing at the Maryland Insurance Administration, or MIA. And the MIA appreciates the opportunity to share its support of Senate Bill 227, which is a departmental bill. Senate Bill 227 protects consumers and carriers by limiting the circumstances in which an insurance carrier may terminate an individual health benefit plan, both on and off the health benefit exchange, due to a premium deficiency of $10 or less 30 days after written notice. While not a widespread issue, the MIA has encountered circumstances where policies have been terminated when premium payments were short by a minor amount, even as low as pennies. When policies are terminated due to non-payment, then the individual or family covered by the policy cannot obtain another individual policy until the next open enrollment period for the following January 1st. In 2022, 242,163 Marylanders were covered by individual health benefit plans. Of these, 72.9% were sold on the exchange. Federal law permits exchanges to allow carriers to implement a policy under which carriers can consider enrollees to have paid all amounts due if the enrollees have met a threshold set by the carrier of a percentage due. If the threshold is met, then the carrier may consider that the enrollee has paid in full and not triggered a grace period or termination for non-payment of premium. Carriers have inconsistent policies, and the option does not currently exist off of the exchange. If a policyholder owes only $1 for their monthly payment after any tax credits, and the carrier's threshold is 2%, then a policyholder who mistakenly enters 10 cents into their bill payment screen would be terminated. The MIA believes that setting a deficiency limit of $10 or less balances the practical and economic effects on consumers and carriers by protecting consumers who inadvertently underpay their premium by a de minimis amount by preventing termination of their policy under certain circumstances, protecting consumers who seek to cancel their policies by stopping payment by requiring that the policyholder must make some payment. They cannot skip entirely. Protecting carriers from having to keep a policy active, even though premium payments have not been paid at all. Protecting carriers by limiting how often and how long a shortage may occur. And the proposal seeks to ensure that the amount of underpayment is minimal. Senate Bill 227 intends to protect policyholders who have limited options if a policy lapses due to the limited times when enrollment in a new policy is permitted, while not unduly burdening carriers. For these reasons, the MIA urges a favorable committee report on Senate Bill 227 and thanks the committee for the opportunity to share its support.
Thank you very much for your testimony. And Joanna?
Hello again, Johanna Fabian Marks, Director of Policy and Plan Management at the Maryland Health Benefit Exchange, here to testify in support of Senate Bill 227. As was shared, we have also occasionally encountered instances where policies were terminated over a pretty nominal underpayment, usually through some kind of unintentional error on the consumer's part. So we support the bill for all of the reasons articulated to provide some standards to safeguard Marylanders from a very severe consequence for a small mistake.
Do I have any questions for this panel? Nope. Thank you very much for your testimony. Next, we have two people that were favorable with amendment, Matt Celentano and Allison Taylor.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. We appreciate the intent of this bill. Kaiser certainly wants to keep their members and not terminate them for owing a de minimis amount of premium. We met with the MIA about some technical concerns we have with this proposal. We had a productive meeting with them, so I hope we can work on some amendments for this. Our main concern or question is how this would interplay with our requirements to offer grace periods under the Affordable Care Act. The Affordable Care Act requires us to if a member does not pay their premium to give them a 90-day grace period, after which we can elect to set a premium threshold where if they have a de minimis amount like what the MIA was talking about, we could still keep them on the books. So we've had a question for them where the 30-day period that they're talking about would fall within that. We thought originally that this was going to be another 30 days after that 90-day grace period. It sounds like their intent is to make that somehow concurrent with the 90 days. So we need some clarification about that. We do have, and Kaiser does have a policy on this of our payment threshold is 98% of payment due, which is scalable depending on what the premium owed is. And we think there's certainly controls and protections for our members for this. While it might be counterintuitive to you, we do have concerns with this $10 limit. 15% of Kaiser members who are on exchange owe less than $10 in premium for each month. And so in the scenario at the end, Matt can finish my point. Thank you.
Madam Chair, members of the Senate Finance Committee. Hi, Matt Celentano here today on behalf of the League of Life and Health Insurers of Maryland in support of Senate Bill 227 with amendments. Supportive to be in the session, I think, is a good way to start because it's going to change. In some ways, we believe that this bill is sort of a solution looking for a problem. We're unaware of any complaints in the space, and each carrier actually, and all 5 commercial carriers have an existing policy to ensure that consumers don't have their coverage canceled. The last thing any of the carriers want to have is to lose any of their members. But the carriers are also required to make a good effort under the Affordable Care Act to collect all the premium. And in fact, if the individual does not pay their share of the premium, the IRS will not allow a premium tax credit for the next month. So it's understanding that the feds will also soon be releasing guidance in this particular place, and we don't want Maryland to get out in front of that. So if the committee, if you see fit to move forward with this bill, we have a couple of suggestions that we think that would solve the problem for now. And that would be, one, to mandate that all carriers do have a policy, and it is my understanding from talking to them that all of them do have a policy, they're just not aligned. And 2, we would like to see a change from the dollar amount to more of a percentage base, which I think Allison was sort of alluding to, that would, I think, reflect, one, a better snapshot of the consumers and their issues with this, but also it's operationally much easier. Like I think Allison alluded to, we had a long conversation with all the carriers last week with the MIA, and we would love an opportunity to continue to work on this because we do support the intent of this legislation. So thank you very much.
Thank you for your comments. I would like to ask the MIA if they can get us a list of the complaints where this happened in 2023, the most recent year. So Mary, could you get us either a list or the number of complaints where this happened in 2023?
We will work on that.
All right, thank you very much. Do I have any questions for this panel? Thank you very much. Allison, it's always nice to see you back in the.
Yes, likewise.
Thank you.
Our next bill is Senate Bill 210. Theodore Delbridge, Robin Elliott, and Christina Curley. Would you like to come to the table, please?
Madam Chair, members of the committee, good afternoon. I'm Dr. Ted Delbridge, Executive Director for MEMS, the Maryland Institute for Emergency Medical Services Systems, and thank you for considering Senate Bill 210, which I hope is fairly straightforward. Prior to the COVID pandemic, EMS paramedics in Maryland were authorized in statute to administer hepatitis and seasonal influenza vaccines only to other public safety personnel within their jurisdictions. Via executive order and subsequent legislation, twice as it is, that was extended to COVID and seasonal influenza vaccines to the public as well, all under strict guidelines. Senate Bill 210 seeks to extend that option beyond its current sunset date of January 1, 2025, without any other notable changes. Tens of thousands of COVID and influenza vaccines have been safely administered by EMS personnel in Maryland. At least 34 other states currently authorize their EMS clinicians to do similar work. EMS personnel extend the public health reach to where people actually are. It's noteworthy that only 1/3 of Marylanders receive influenza vaccine each year. This is particularly problematic when hospital emergency departments are nearly overwhelmed with patients with potentially avoidable respiratory viruses, as has been the case in recent weeks, leading to prolonged waiting times, delays in receiving new patients arriving by EMS, and on many days, more than 600 patients boarding in hospital emergency departments because of no available hospital bed for them to be admitted to. Quite frankly, this should be an all hands on deck, including EMS, public health concern. The vaccines are offered under strict guidelines, not during 911 encounters, but during special events and mobile integrated health or MIH prearranged encounters with patients. They're only under authorization of a physician, usually the local EMS medical director, and only when coordinated with the local health department, hospital, or hospital system. So this isn't EMS folks out doing their thing sort of in a renegade fashion. It's quite organized. It is only appropriate to make this option available to EMS jurisdictions for the benefit of their communities. And thank you for your time. We currently urge a favorable report for Senate Bill 210.
Thank you, Dr. Delbridge. Nice to see you again.
You too.
I would like to know if you could share with us examples of when this happened during COVID.
Well, during COVID, you mean the circumstances under which vaccines were given?
Yes.
Many of the local health departments set up clinics in schools and other places, and they enlisted the help of EMS personnel to be the vaccine givers while they managed the logistics of it all, the paperwork, entering the vaccine immunet, making sure the vaccines were adequately stored and cared for. And this was done a lot. EMS personnel administered more than 80,000 vaccines. And just in the past 2 flu seasons, the Baltimore City Fire Department, in cooperation with the health department in Baltimore, has administered more than 1,100 influenza vaccines. COVID vaccination rates have decreased significantly during this most recent season, but influenza is a problem that comes at us every year. And it's not an insignificant event when it happens in Maryland, as in any other state.
Thank you for that. Do I have any other questions for Dr. Delbridge? Senator Hershey?
Thank you, Madam Chair, and Dr. Delbridge, thank you very much. Not necessarily in opposition to the bill, but I just want to understand something. The bill itself mentions that the vaccines can be administered if the immunizations are provided in a certain manner, but then it says authorized by the Institute. That doesn't mean that you guys are deciding what type of vaccination or immunization gets
No,
administered.
that's correct.
Right.
But for an EMS jurisdiction to have a plan to collaborate with the local health department, we approve that plan. So we don't approve the individual vaccinations to a person, but we ensure that there's adequate planning and coordination with the local health department, that there is in fact a plan for storage of the vaccine in an appropriate manner, and that the vaccinations registered with Immunet, so it accrues to the patient's long-term healthcare record.
Okay, so all of that needs to take care before or taking place. Then just another interesting thing, and it mentions influenza, and then it says specifically 2019 COV immunizations. It doesn't say COVID-19 or anything else. And I just looked to see what that was. Is that the appropriate name for this disease or what was out there anymore? Or does that need to be updated, or what are your thoughts on that, if anything?
I'll defer to the committee council. The initial legislation that made this provision,
right,
from a lay person, not a legal statutory sort of guy, was sort of composed in a complicated way, and so subsequent efforts to extend the sunset of that have been equally as complicated. Okay. I think it's understood, and so I think everybody gets it.
Right.
But probably we could make some clear language so that when somebody's reading it 25 years from now, they get it.
I appreciate that, because I don't think it's not that we don't understand it, and you're right, but it does seem like, I think probably when this was written, as I did look up, I think the former name was 2019 nCoV, which was the novel coronavirus, and I guess it's changed since then. I'm just wondering if we are looking at this legislation, and we're making a change to it, should we use the appropriate terminology if that's what it is at the time? So we can check with committee staff on that as well. So I appreciate that.
Thank you, Senator Hirsch. I do want to say the bill only extends this for 5 years to 2030. So we're not putting this too far into the future. As a sunset 2030. We keep fixing it. Thank you again. Who's next? Christina Curley, would you like to go next?
Yes, hi, thank you, Chair Bidel and members of the Finance Committee for allowing me to come and testify today. My name is Christina Curley, and I'm here on behalf of the Maryland Association of Counties, or MACO. And MACO supports Senate Bill 210 as it extends a critical initiative for local health departments to carry out targeted public health initiatives by authorizing paramedics to administer specified vaccines with proper training and oversight. The extension of the sunset of Chapter 404 of 2022 by 5 years will help to advance local efforts to improve vaccination rates, providing one of the most successful and cost-effective services to prevent disease and death. MACO advocates that public health and emergency agencies be properly supported with necessary funds to support staff, services, supplies, and technology, not only in times of crisis, but for the everyday preventative and responsive health services they provide. MACO supports Senate Bill 210 and urges the committee to give a favorable report. Thank you.
Thank you, Christina. And Robin Elliott, thank you.
Good afternoon. Robin Elliott here on behalf of the Maryland Nurses Association in full support of the bill. EMS providers the nurses think EMS providers are very competent to give vaccinations. And we all know they're not going to be enough nurses anytime soon. So we need them as part of the team. So we support the bill. Thank you.
That's a very good point, Ms. Elliott. Do I have any other questions, please? Senator Reedy.
Thank you very much. This is probably for anybody, but maybe for you. I missed an opportunity earlier, but I guess the one question that maybe is a little bit of pushback here is, we understand the need for flexibility, but when you're offering vaccinations, and this would only be for influenza and COVID-19, correct?
Correct.
But when you're offering them in an emergency type of situation, it's a little different than now. It's a COVID-19 vaccination or a flu shot are available all over the place. I mean, I can't go anywhere without getting it, whether it's a pharmacy or whether it's my doctor's office, without being hammered with, like, we have them here, they're here. And I know there's some communities that are underserved, but what were we doing about flu shots before we passed this bill, before COVID-19? Well, because we obviously flu was always a concern, and there were some communities that were underserved. Were we not? What were we doing before COVID-19?
We were relying on people to go to their primary care physician's office or their local pharmacy and get influenza vaccine, and only a third of them are availing themselves of that opportunity to do that. And then we face a rush in emergency department services every flu season. This has been done in other places for quite some time. We're a little bit behind the curve, where a local health department or hospital system sets up a clinic place where people are, where they're walking by and they say, oh my gosh, I could get my flu shot right here. Instead of going to the local pharmacy, we have to make an appointment online 2 days in advance and show up at a particular time. And, you know, we just make it convenient. The other time that EMS is particularly successful in vaccinating people is when they engage folks in mobile integrated healthcare. So that's a prospective encounter with a patient who they know is a frequent caller to 911, for example, and they make arrangements to see the patient in their home, and they do other healthcare prospective kinds of things, preventative kinds of things, and they can offer a vaccine as part of those encounters. So they're not giving vaccines during 911 emergency encounters. That's not what we're advocating.
I assume not, but yeah. I guess my question, and maybe particularly as it relates more to COVID-19 vaccine than influenza, because obviously the flu shot the mix is different every year, but roughly there's pretty low risk. But with the COVID-19 vaccine, there have been situations where people have had sort of weird reactions because it's a new and it really calling it a vaccine is sort of interesting because it doesn't really prevent you from getting it. It prevents you, perhaps the argument is it prevents you from having severe symptoms. I guess my question is, somebody who's fire EMS doesn't have the medical background on the person when they're encountering them in a situation. And obviously we had this as an emergency because we were trying to get it out as fast as we could. But now I just worry, I don't know if you can speak to what kind of medical background knowledge will they have on somebody to know whether they might be at risk for some of the side effects?
Past reaction to the similar vaccine is the best indicator that they're going to have a potential reaction again. They follow the manufacturer's guidelines in terms of observing patients after the vaccine is given. They are the best. They're who gets called when there is an adverse reaction to a vaccine. So they're already there to respond. And we are unaware of any serious adverse events in the tens of thousands of people who have been given vaccines by EMS so far.
Okay, thank you very much.
You're welcome.
Do I have any other questions for this panel? Thank you very much. We did have one person sign up in opposition. She's not in the meeting, so we won't be hearing testimony from that last witness. Thank you very much.
Thank you.
Our last bill of the day is the Department of Labor for an administration bill, a departmental bill, and thank you for your patience, Commissioner Dove. And also, we're going to have someone virtually that's also in favor, Deborah Rapazio.
Rapazzo.
Thank you. Thank you for joining us. You can start.
Thank you. Good afternoon. For the record, my name is John Dove. I'm the Commissioner of the Office of Occupational Professional Licensing at the Maryland Department of Labor. Online with me is Executive Director Debbie Rapazzo, who oversees our Office of Cemetery Oversight. I'd like to thank Chair Beidel and all the Finance Committee members for allowing me to introduce SB 224, entitled Cemeteries, Burial Transit, Permits, and explaining why the passing of this bill would benefit all Maryland citizens. This bill would make it easier for family members to locate the final disposition of cremated loved ones. Currently, an ancestor's burial location is listed on the death certificate, typically identifying the cemetery the loved one is buried in. However, if the loved one was cremated, the final disposition listed on the death certificate is most likely the name of the crematory, which in most cases is not where the remains are placed. This bill would add an explanation on all death certificates, listing final dispositions of cremated human remains by stating who received the remains and their relationship to the cremated person. This would provide family members the additional information necessary to assist them with locating a loved one's remains. It is a small change, but an enormous help to a descendant having the heartbreaking experience of looking for an ancestor's final resting place. Passing SB 224 could prevent or ease some of that heartbreak and give these families peace. Thank you for your time, and we ask this committee for a favorable report. Thank you.
Thank you, Commissioner. And Deborah, would you like to testify?
Hi, thank you, Chair Bidel and Vice Chair, Senator Cosmer. I agree with everything that Commissioner Dove has, has stated. I get calls almost every day for people hunting for their loved ones. And if it's a traditional burial, full body, a lot of times I'm very successful. But if it is someone that has been cremated, it's much more difficult because the final disposition of someone that's cremated is at the crematory. So I hear the heartbreak, and this would just be a very positive thing for all the citizens of Maryland and really all across the country and the world that have loved ones that have been cremated and, in Maryland. Thank you.
Thank you. Thank you for that work. I'm sure it can be very difficult with families. Next we have Christine Simmons. She is favorable with amendments. Christine.
Hello, my name is Christine Simmons. Today I represent the Coalition to Protect Maryland Burial Sites. It's a statewide nonprofit dedicated to identifying, protecting, and preserving cemeteries in Maryland. In my 35 years of researching in Anne Arundel County, I've only found 38 burial permits, 4 of which are transit permits. Under the present laws, there is no requirement for any official to keep these vital records for any period of time. Not the funeral home, the state's attorney, or Maryland State Archives. Sometimes there is no known cemetery owner or no clear title. In some cases, remains have been moved without any attempt to contact family members. After a close review of Senate Bill 224, the Coalition recommends that a copy of the burial transit permit be kept by the cemetery property owner or agent at both the initial and final destinations. There should be a significant fine imposed if all procedures are not followed, with the fines to be deposited in a fund at the Maryland Office of Cemetery Oversight for procedures not followed, with work at the cemetery is not usually eligible for other funding. We suggest 2 specific wording changes to the current law. One is page 1, line 23B1, to remove from the state from the bill. The second is page 2, line 26E1, the requirement documentation of an attempt to reach a family member in advance of remains being reinterred within the same cemetery. The annotated code of Maryland currently addresses burial sites in multiple sections. Thank you very much.
Thank you. And we have one more witness with a slide presentation, David Zinner.
Hi, my name is David Zinner. I'm a consumer representative on the Maryland Advisory Council for Cemetery Oversight, but my testimony today is not as a member of that advisory council. I also consult and advise the Rosa Bonheur Cemetery. I'm going to start, well, it's sort of a shame that I have to do some depressing testimony here at the end of the day being last. The Rosa Bonheur Memorial Park, you can see what it used to look like. Beautiful picture, pet burials and human burials. But then if you go to the next slide, you can see some recent desecration that happened there. And it's not the normal kind of desecration. Let's see, can I do this myself? Yes. This is not the kind of desecration where you have graffiti or where you have people toppling tombstones. This is probably desecration that was done by, we think, maybe the developer next door. But there were tire tracks and marks all messed up. It looked like it was very deliberate where they dug up graves. You can see where the tree is knocked over. That tree was a beautiful tree that got messed up. This is where they disinterred human burials and then left a pile of markers, footstone markers, under a tree. And this is where we believe, and this is the worst part of all, this is where we believe they did a trench burial for the 8 humans that were disinterred and buried in a mass grave with no markers. Now, what does this have to do with SB 224? SB 224 requires that there be a health department permit when there is a disinterment that's authorized by the state's attorney. In this particular case, the state's attorney authorized a disinterment. And since it was in the same cemetery, it wasn't, there wasn't a health department permit needed. We're suggesting significant, serious changes, which we submitted in our written testimony, so that things like this don't happen again. We'd be glad to take questions. I want to keep to my time.
Thank you, Mr. Zinner, for that very sad presentation. Do I have any questions for Mr. Zinner or for the previous panel? Commissioner Dove or Deborah, represent, any other questions?
Yeah.
Oh, okay.
No, I just want to know where it's located.
The Rosa Bonheur Cemetery is located in Howard County in the Elk Ridge area. It's on Route 1, right off 103. It's across the road from the Meadow Ridge Memorial Park, if you know where that is.
Yeah.
It's us, you know, it's been there for like 90 years.
Thank you. Do I have any other questions? Oh, Senator Mott.
And the legislation would only apply for recognized cemeteries, is that correct? Sorry.
This is mainly about the crematorium right now, crematory. So that's what's on this bill. The amendment is what he's proposing.
I just asked a question, since
Right.
we're talking about this and have that.
So only recently have pet cemeteries become regulated by the department, by the Office of Cemetery Oversight also. The cemetery that I'm showing here, the Rosa Bonheur Cemetery, has both pet burials and human burials.
Together.
I guess the question is if there is a cemetery, well, what is the penalty for disinterment? Unauthorized.
Yeah, the state, it's in the criminal code.
Yes.
And I don't recall the exact penalty, but part of the problem is that there's no one overseeing the disinterment. Once the state's attorney says, yes, you can do it, there's no one watching to make sure it gets done correctly.
Right.
So it's unclear whose responsibility is, and that's part of what we're suggesting be changed to the Office of Cemetery Oversight, because they understand cemeteries, and the state's attorneys want to deal with criminal matters, not matters of developers deciding they want to disinter numerous bodies to make room for development.
Thank you.
Any senators with any other questions for this final panel of the day?
We always get to go last.
Thank you very much. Thank you for your presentations, and that ends the briefing for today. Thank you.